Company, that's what we do. We go there and we like to do a lecture. We like to do rounding and meet with decision makers to talk about how we can implement things. But like, you know, as I teach somebody to do, quote, my way, 300 people learn it the other way, so it never gets extinguished. You know, we've got like, it's really deplorable in this country. And I don't mean by IR and the vascular access nurses and vascular surgery. I mean by critical care, anesthesia, the emergency department, general surgery. You know, they learn this way, you know, and there's a book called Why Hospitals Should Fly. And in it, the author is a guy named John Nance, and he spoke at the AVA convention. And in it he says, the most dangerous words in the English language are, because that's the way we've always done it. So you can make a mess because we've always done it, you know, but I'm probably done. Kristen, anything to say back there? You're good? Skin Guru? All right. Lovely meeting you all, and I mean, all right. We have a question?
About a month ago, I saw a dressing exactly like the triple lumen that was. What I thought it was interesting because I mentioned that too. We had like a debrief after that, and the charge nurses were saying, "Oh yeah, it's just a teaching hospital."
Yeah.
Like, and then the next nurse said, "Oh yeah, it's a teaching hospital." Mm-hmm. So how do we change? I mean, you
stop right there. Stop right there.
Yeah.
See, the nurses are used to getting junk. It's just part of their day. Like, she puts extra, she'll have dressing equipment by the bedside. They're so used to getting it. It's just part of the noise of their job. You know what I mean? Like, so it's presenting evidence. You know, like, it's not maybe the dressing belongs on the chest. Like these strong recommendations. I'll provide the video of it. You know, and then just see, like, all you can do is give them evidence, show them stuff. If they're not open-minded, I mean, about 8 years ago, I predicted there'd be an avalanche of the vascular access nurses moving into this procedure. I've been wrong to this point, but I think I'll be right. I think see, if you tell the nurses what the rules are, they'll do it. The docs just think they don't have to listen to the rules, you know? So, you know, you might need a doctor to doctor, you know, come in, bring me in, do a lecture, do rounding, you know, and see if we get one person to bite, you can start to make the change. But if nobody's in charge, see, if nobody's in charge, you miss out on the last 10 advances. You know, how are you going to get equipment? Like, how are they going to get the micropuncture equipment? How are they going to get EKG-based tip location? Because nobody's in charge to drive the change, and they don't know this stuff. You know, but my heart goes out. My heart goes out when you're seeing crummy practice. And then, like, what are the IPs going to do? Like, say, oh, on Unit 3A, we had 4 CLABSIs last month. I'm like, hey, that stuff is great. Don't get me wrong. I mean, like, that stuff is great, but, like, you got to put the catheters in properly and dress them properly. You know what I mean? Like, and then track. You know, like, we're not doing the basics of this thing. And then there's all kinds of fancy statistics and stuff like that. Like, we're lost. We're lost if we're not doing the basics in this thing. All right, I know I made that point. All right. That's it. That's all I got. A question. We got, all right. Have those questions ready. Okay.
So, I was asked by an intensivist to teach him how to use ultrasound-guided ultrasound machines to access the IJ to do central line. Honestly, it's kind of like, it's very difficult for that. Sometimes it's very difficult for the physicians. It's either you get it, you don't get it, or you take a long time to learn it. He can put in a central line in, you know, without using ultrasound less than 10 minutes. But when I see him using the ultrasound, he was struggling. He was trying to do his best. But so I feel like having a physician like you being so good at ultrasound guidance is a luxury, but not a lot of hospital has that privilege. And so when you do a central line in the subclavian vein, it looks really nice, it looks very good, but still it is a short-term CVC, right? And are we still just keeping it for 7 days at your hospital, or are we keeping
No.
it for longer?
No. Couple of things. First of all, it's the axillary vein. Training consists of didactic, like we did today, simulation on a phantom, and proctored insertions, you know what I mean, by probably not yourself. I mean, I don't know if you have a big experience with jugular veins or not, but you have a big experience with ultrasound. So like, there are three components to this. Like, there's a formalized way to teach people. And it's not like, hey, vascular access nurse, you know how to put in PICCs, come show me how to do the jugular vein. Like, that's not a reproducible thing. And I had another point in there I was gonna make, but it slipped my mind.
Since the central line now, right now is in the
Duration.
The
Duration, right. So when we put in an acute central venous catheter, we leave it as long as there's no it's clinically indicated, to remove it. We do not remove it for day 14, day 29, day 56. If it's working and there's no sign of infection, we leave that catheter in place. Now, we put them in properly. Hopefully the dressing doesn't have to be changed. Not the mess on the neck, where it's like that I want to get rid of, I want to get rid of this afternoon. But yeah, we put them in properly and it can stay, until there's a clinical reason to remove it.
Because I think in the INS it does say the difference between long-term is about the tunnel or non-tunnel. So I think in our hospital, when it's a non-tunnel catheter, it's good for 7 days. And then when the catheter is tunnel, it's good for longer term. So I think a lot of times when we have a central line in the IJ, usually they're less than 7 days, and then if the line needs to be replaced, then they do a PICC or the patient go to IR and get a subclavian tunnel catheter.
Yeah, it's usually an IJ tunneled out to the chest. Now, a lot there. So I think in the IFU for the triple lumen catheters, I think it says 29 days. But we don't remove it on day 29 if it's functioning. If you're going to take them out on day 7, find where that came from. I think it's made up baloney. You know what I mean? If it's a well-placed line. Now, I know hospitals where as soon as they put in the IJ, they write an order, insert PICC. We're completely against that. But if they're putting the IJ in crumbly, there's a place for it. You know what I mean? So in other words, the fix is irrational, but the insertion's irrational. You know what I mean? There's nothing rational about any of this. It comes down to put the catheter in properly to start. Yeah. And they do not have to be removed because and a lot of times they'll say, look at the hospital policy. What's the hospital policy based on? You know what I mean? There are people that are calling the nephrologist to see if they can put a PICC in the patient with CKD. Why call a nephrologist? You just don't do it. You know what I mean? Unless there's some extenuating circumstance. So what you're saying, the basis for it in your hospital is unclear to me at best, and I think it's wrong and people made up silly stuff, but that's how they practice. And they teach the next generation this silly stuff. You know what I mean? That's how you get into, then somebody's going to become a chief of critical care and he's going to tell, we take it out on day 7. You know what I mean? Just carries it on, forever.
To me, it sounds like you guys have really good insertion practices and therefore that sustains. I'm assuming that's why it 100% makes sense to me. That's why you don't change them, at 7 days. Practice probably across the border, I would assume, look like those crappy ones.
Yeah. Right. That's the difference. That's why when people say IJ, it's so varied. To me, it means a mess on the neck. When they tell you IJ, they act like they're proud that they put it in the IJ vein. You know what I mean? And there's a way. Put it low in the neck, rotate it down so that the gravity's working with you. I'm okay with all that, especially if the patient has chronic kidney disease.
It's unfortunate that the guidelines have set standards for 7 days because
what guidelines?
It's actually CBC also did say that INS.
No, wrong. No. Yeah, no, they're no. No, there's no, listen, the CDC in 2004 said do not change a line. There's no schedule change for a line. So whatever you have for 7 days, you can show me if you want, but like you're wrong. But no, show it to me. Show it to me. No, there's no 7 day. There's no 7 day removal. There's not. Yes, ma'am.
So what's your guidance on the number of lumens? Because I feel like sometimes physicians put in triple lumens just in case. But my understanding is that's higher risk the more lumens you have in.
Yes, it is higher risk. It's like putting in 3 catheters. So if that's the only device you have in your institution, that's what they're going to get. So we used to have single, double, triple, and we used to have 15, 20, 25 centimeters, and even 30 centimeters. We'd have different lengths because people come in different sizes. See, this comes from nobody's in charge. Nobody that understands vascular access is in charge. So we know what happens, supply chain becomes in charge. So they buy this one triple lumen catheter, which is kind of a workhorse. I mean, you use it, it's 20 centimeters. Sometimes anesthesia has the 16 centimeter, which I think is worse. See, nobody that knows vascular access,
So we have the different lumens though, and physicians still tend to go for the triple lumen just in case. So is that education that's needed?
Yeah, or it's get the vascular access nurses to step up and doing the procedures. Yeah. Occasionally, somebody will be pretty sick and you're not sure how many lumens they need. If you want to err on the side of giving an extra lumen, I got no problem with that, but don't make it the routine that everybody gets 3 lumens because they may need it sometime in the future or they may develop pancreatic cancer. People make up stuff, and because they have an MD degree, they believe it themselves. There's a lot of made up stuff out there, but yes, they should get the right number of devices, the right number of lumens, based on your clinical assessment, of the patient. All right, infection prevention is, start going up to Dr. Dunn says, do it this way, All right, love you guys,